Hey, welcome back. Together we will go through the respiratory system. Alright, there's the difference between mechanical respiration and cellular respiration. Both require oxygen, but mechanical respiration is more of just like the process of exchanging oxygen for carbon dioxide in the tissues and in the lungs. That's it. While cellular respiration is using the oxygen to help with metabolism, especially in like the electron transport chain and the Krebs cycle. So the respiratory system is divided into two parts: the conduction part and the respiratory portion. So the conduction portion is also separated into the upper respiratory tract, which is going to be the nasal cavity, the paranasal sinuses, along with the nasopharynx. And the lower respiratory tract starts with the larynx and then goes down into the lungs. So the terminal bronchioles are part of the respiratory portion, and they play a role in cleaning and humidifying the air. So why does the air have to be humidified, right? So it's actually really for scent purposes. Odors are stronger when they are like heated and humid, but also it plays a role in helping the lungs expand. So the alveoli are there for the gas exchange, and they have the elastic and reticular fibers in order to give it shape, along with some collagenous component. And those allow the alveoli to expand and contract in order to expel the air. And the respiratory epithelium is going to be ciliated in order to move, antigens and particulates out of the respiratory conducting zone more into the esophagus, so we can either cough or swallow the particulates. And they're going to be pseudostratified columnar epithelium. So the walls are going to be made out of the mucosa, which has the pseudo-stratified columnar epithelium. So it's not perfect layers. You see there's a little bit of mismatch. That's why it's pseudo-stratified. And there it has a lot of cilia, along with the goblet cells that secrete mucin. The Kolchitsky cells, which are going to be, interspersed, along with the basal, the brush, and the Clara cells. So the lamina propria are going to contain these, and the epithelium changes eventually, like as you go further down. It's going to start off columnar and then gradually change into cuboidal cells. The vocal cords are different from the rest of the epithelia in the respiratory tract because they have only stratified non-keratinized squamous epithelium, no ciliated cells or glands. So these have to be moistened when you swallow and by the glands above it in the false vocal cords. Here's the vestibule. So here's the true vocal cords. There's no glands. Look, it's like neat, even layers, so stratified. And here, the vestibular folds or the false vocal cords will have like glands in order to like trickle down and lubricate the true vocal cords. So the type 1 alveolar cells are going to be very thin. It's like 1 cell thick, and that provides the blood-air barrier. The type 2 are going to secrete dipalmitoyl phosphatidylcholine, and that's going to be a main component of surfactant. The columnar cells are going to be ciliated, and the goblet cells are going to be more numerous in the nasal cavity and decrease as you go down to the trachea. The Clara cells are going to replace them in the terminal and respiratory bronchioles. So here are the type 1, they're a little flatter. Type 2, they're larger. And look, there's just like 1 cell thick. These are the alveoli. Okay, so what are the Clara cells? Those are going to be exocrine cells, and they secrete the granules, and they have a lot of mitochondria, but they don't actually secrete like mucus. So instead, they mix surfactant from the dipalmitoyl. I can't even say it. Let's go back. Sorry, it's gonna kill me if I don't figure it out. Here we go. Dipalmitoyl phosphatidylcholine. So that is going to make the surfactant. Well, it's going to take that and make the surfactant in the Clara cells, and that protects the bronchial epithelium by secreting CC16, which is a anti-protease, and that inhibits elastase and neutrophil recruitment and activation. So these are going to prevent the neutrophils from auto-digestion, basically. And trypsin's also, antitrypsin and trypsin is going to play a role in this too. So CC16 decreases in lung diseases, emphysema, COPD. The serum levels are going to increase because they leak across the damaged blood-air barrier. So CC16 is actually very useful. It detoxes harmful substances using the P40 enzyme system of the smooth endoplasmic reticular, and that makes the secretory components in order for the immunoglobulin A to transfer into the bronchiolar lumen, along with lysozymes and enzyme to detox the various inhaled pathogens. The basal cells are going to be the stem cells. Here's your capillary, here's your red blood cells, they're kind of floating around. Here's your type 1 cells, that's your area barrier, and here it's damaged because there's a big old gap right here. Here's this gap. So Kolchitsky cells can only be stained with silver stains, otherwise they'll appear as dark blobs, and they're a part of the neuroendocrine system, and they're fairly rare. They're not abundant, and they lie deep within the epithelium near the bronchial glands inside the lamina propria. And the problem with these cells is that neoplastic transformation will result in small cell lung cancer. So basal cells are going to be small and round, and they are the stem cells, and these can move across the epithelium, and only one is the only one that can reach all the way up to the lumen. The rest of the cells stay static. The brush cells are columnar cells, and they have the microvilli, and they act as the chemosensory receptor. Okay, so the lamina propria is going to be filled with elastic fibers along with capillary, and they get thinner in the alveolar sacs until the sacs are only made of the elastic and reticular fibers. The glands there's a variety of glands, and they're gone in the bronchioles, past the bronchioles into the acini. Smooth muscle and elastic fibers will increase from the bronchi to the segmental bronchi, and they're mostly prominent in the large bronchioles. And then they get less and less until the respiratory and the terminal bronchioles only have 1 to 2 layers. And then there's only a couple strands in the alveolar ducts, mostly just to give the ducts some structure. And in the lamina propria, lymphoid aggregates along with the malt will increase as the bronchi get smaller. Why, right? Why is this important? It's because it's coming closer and closer in contact with the air, and the air that we breathe is not pure oxygen or a pure not oxygen nitrogen mix. There's always some kind of particulate in the air. So of course there has to be a lot more immune responses closer to the area where more air can get in. So there's going to be a lot of plasma cells with IgA at the ready, and then Bowman olfactory glands are going to produce the fluid that allow the flow of odor molecules right at the cribriform plate. So underneath the mucosa are the submucosa and the cartilaginous layer, and they have some vessels, not a lot, but they have some. The serum mucous glands are more predominant in the upper respiratory tract, but they're gone past the bronchioles. Of course, because we don't need any more secretion, right? We need to replace that with more white blood cells. So the cartilages, of course, we're going to support and maintain the lumen, but they're gone past the bronchioles. Instead, it's going to be like reticular fibers. So the elastic cartilage are going to be in the small laryngeal cartilages. Remember, in the trachea, this was like the arcuate and the cuneiform cartilages. And then hyaline are going to be in the nose and the large laryngeal cartilage, along with the tracheal rings and the bronchi plate. The rings of the cartilages in the bronchi are going to be like a full ring. It's not going to be like a half ring, in sort of like in the trachea. And there's going to be skeletal muscles in the nasopharynx and the larynx, and then that's replaced by the smooth muscle by the time we reach the trachea. So the adventitia is a fibroelastic vessel tissue, and it's very vasculated, and it surrounds cartilage or smooth muscle. It just kind of provides the cartilage and whatever inside with some nutrients, and that's why, like, cartilages are avascular, and they have to get all their nutrients and whatnot from the adventitia. Okay, so nose is made out of bones, cartilage, and fibrofatty tissue, and the mucosa are going to have keratinized stratified squamous epithelium lining the entire nose and nasal cavity, and inside are going to be some vibrissae, which are the hairs to trap particulate, and on the outside there's going to be sweat and sebaceous glands. Deeper into the nasal cavity, it's going to transition into non-keratinized stratified squamous epithelium, but in the olfactory region, so near the cribriform plate and the concha, the mucosa is going to line everything. And in the respiratory region, toward the middle and inferior nasal conchae, along with the septum and the goblet cells, they're going to have more secreting cells, more like goblet cells. And the lamina propria in the nose are vascular, and they have plenty of glands, and they work to warm and humidify the air. And then the folds in the lateral wall are made by the concha, and they cause the airstream turbulence in order to stir up the odor particles so it can reach the cribriform plate, and we can smell things better. Okay, so the olfactory region is going to be like the true respiratory epithelium, and that's going to be less cilia. Instead, they're going to have more like olfactory neurons, supporting cells, and basal cells. Basal cells, of course, your stem cells. And the olfactory cells are going to be your bipolar neurons. Dendrites are going to be at the luminal ends, and they don't have any like motile cilia, but they have some stuff that like poke out in order to receive the odor molecules. And then the axons will pierce the cribriform plate and eventually merge in order to make cranial nerve number 1. And the supporting cells are going to be the columnar cells, and those have microvilli, and they're replaced. The cells of the olfactory nerves are replaced every 2 to 3 months, so a decently long time to live. So there's a bunch of paranasal air sinuses. We covered that in anatomy. And the mucosa is thinner, and they have less goblet cells. And with the less goblet cells, I have more motile cilia. So these are really just for and they're just here to lighten the load of the head and use as voice resonators, which is problematic since there's less goblet cells, there's less acidic mucins to protect it. They're kind of prone to sinusitis. And the lamina propria continues the periosteum, and that can be quite serious, especially if you have severe sinusitis, especially in the maxillary sinus, because it's the largest, and it goes straight into it can lead straight into the brain. Okay, so the nasopharynx is going to be made out of the respiratory epithelium along with the lamina propria, and it's vascular, and they have a lot of glands along with MALT, which is the mucosa associated lymphoid tissue, and those will form the tonsils And when a tonsil is inflamed and there's mass in it, it's called adenoiditis. That's it for now. Thank you for your attention and good luck studying.